Hello everyone, myself Dr. Prashant, and today we are going to discuss about Perthes disease. What Perthes disease is? This is idiopathic avian of femoral head. So by the word idiopathic, we do mean that this is not happening secondary to any cause, like not because of neck femur fracture, not because of dislocation of hip. And why are we discussing it as a different entity but not as avian of adults? Why is it different from avian of adults? Is that in Perthes, revascularization of femoral head happens always. But in adults, once the avian of the femoral head is established, it will remain devascularized for the entire life of that particular individual. That is the reason we are discussing this disease as a different entity than avian of adults. So this we have already discussed. This is idiopathic avian of femoral head in adolescent children where revascularization will always happen. Now coming to different associations which are found in this disease. Firstly, since this is idiopathic condition, we cannot say any particular cause which is causing this disease. So there are certain associations which have been described in the literature. The first one is trauma. Secondary to trauma, hematoma formation in the capsule can lead to increased pressure and which can cause avian of femoral head. This is one theory. The second one is transient synovitis. Following transient synovitis in certain children, the Perthes can develop. This is another theory. And some authors do believe that children with ADHD, that is attention deficit hyperactivity disorder, are also prone to have this disease. And last, that is hypercoagulability disorders are also known to have Perthes disease. One association that we should always keep in mind, and that association is very important in Perthes disease, is smoking history for parents. So passive smoking is an important association for development of Perthes disease. Now coming to the blood supply of femoral head. This is very important to understand why does Perthes disease develop in children who are at the age of 4 to 8 years. So firstly we should know that what is the blood supply of femoral head. Femoral head derives its blood supply from 4 sources. One is ligamentum teres, foveal artery. Second is it derives its blood supply from profunda femoris artery, from which arises 2 arteries. One is medial circumflex femoral and another is lateral circumflex femoral artery. Third is artery around greater trochanter, which arises from superior gluteal artery, and fourth one is inferior gluteal artery. These arteries do form trochanteric anastomosis. So these are the 4 arteries from which the arterial supply of femoral head comes. The last 2 ones, these 2 ones are not very important. The first 2 ones are important. So we will be discussing about them. First thing that we should know is medial circumflex femoral artery lies over the posterior aspect. This is the posterior aspect of proximal femur. And lateral circumflex femoral artery lies over the anterior aspect of the femoral head. And they do form extracapsular arterial ring around the femoral head. From this ring arises these transcervical arteries which are going towards the head of the femoral head, and in the capsule of the femoral head they are going to form this subsynovial ring. This is intracapsular arterial ring, and from this intracapsular arterial ring will arise epiphyseal arteries. These are transphyseal arteries and they will supply the femoral head. So this is the blood supply of femoral head. But this blood supply do have certain changes with the age of the patient. What these changes are, we will be discussing right now. One is before the age of 4 years, most of the blood supply comes from profunda femoris. Ligamentum teres is not developed. Okay, so in these children, the sole dependency of the head for the blood supply lies over this region over the transphyseal arteries. And in these children, the physis is permeative for the transphyseal arteries to travel across it and supply the femoral head. But in children who are more than 8 years, the ligamentum teres starts developing. So blood supply comes from both the sources, from this source as well as from the ligamentum teres also. Now comes the gray area. Children whose age is 4 to 8 years. In these children, what happens is that the physis becomes impermeative to transphyseal arteries. The transphyseal arteries becomes less and less source of supply to the head, and the ligamentum teres have also not developed. So in 4 to 8 years of the age, because of the less permeability of the physis to transphyseal arteries, the supply of transphyseal arteries will reduce, and ligamentum teres is also not developed, because of which these children becomes prone to develop avian, that is the Perthes disease. Now coming to the pathology of Perthes disease, it happens in 4 stages. After the transient synovitis phase, the child enters into the phase of avian of femoral head. Avian means the cells of femoral head will undergo necrosis. Once the cells are necrosed, obviously immune cells will come and they will phagocyte it. So that with the phagocytosis of these necrotic cells, the phase of fragmentation starts. So the first phase was transient synovitis, the second phase was avian, third phase was fragmentation, and after the completion of fragmentation, new woven bone starts getting formed again. This is the phase of revascularization and reossification. So these are the 4 phases in the pathology of Perthes disease. Coming to different classification systems which have been defined for Perthes disease, the most classical one is Waldenstrom's classification, who defined avian in 4 stages. These stages we have already discussed. The first was stage of avian, in which on X-ray you will see sclerosis of femoral head. The second stage is stage of fragmentation. In this stage, these fragmentation lines starts developing in the femoral head, which is suggestive of phagocytosis of necrotic cells. And in stage 3, new bone starts getting laid down again. New woven bone. This is woven bone is getting laid down again. And in stage 4, that is a stage of remodeling, where the woven bone will become again lamellar bone. So these are the 4 stages which have been defined in Waldenstrom classification. Now one more classification that is again a descriptive one only, which doesn't help more in the management part, is cateral grouping, based upon how much of the head is involved, whether it is 25%, 50%, 75% or more than 75%. Cateral grouped the disease into 4 groups, and this is more of a descriptive classification, would not help much in treatment. Then came a Salter-Thompson classification with the aim of providing some insight what should be done for the management purpose. So this classification was mainly in the fragmentation phase. In fragmentation phase, sometimes a crescent-shaped fragmentation line appears in subchondral region, which is also known as crescent sign. So what is the length of this crescent, whether it is covering only up to 50% of the femoral head or more than 50%? Thompson divided them into 2 groups. Group A where less than 50%, Group B where more than 50%. Another classification, this is a very important classification, Herring's lateral pillar classification. So Herring divided epiphysis. So I am drawing this epiphysis of femur. So Herring divided epiphysis of femoral head into 3 parts. The medial most was pillar A, middle was pillar B, and the lateral most was pillar C. So in this classification, we will be looking at the height of this lateral pillar, and we will be comparing it with the height of remaining femoral head. So whenever the height of lateral pillar is normal, this is lateral pillar type A classification. Whenever the height is more than 50%, but this is reduced, this becomes type B. And whenever the height is less than 50%, it becomes lateral pillar C. So based upon what type of lateral pillar classification, whether it is A, B or C, we will be deciding what should be the management plan. So coming to the another group in lateral pillar classification, BC, which was not initially defined, but later we came to know that there are certain patients where the height could be exact 50%. Where to classify them now? So they becomes BC group. And there are certain patients in which the height of lateral pillar is comparable to the rest of the epiphysis. But the complete epiphysis is very thin. Supposingly lateral pillar is only 2 to 3 mm only. In that case, we will classify that as group BC, and sometimes the lateral pillar height is okay. The height is more than 50 degree, 50%, but it is not ossified. This is seen as rarefied, very radiolucent. In that case also we will classify it as BC. And how does it look on radiograph? I will be showing you just a minute. So this is how a BC group appears. In this you can see very well that this is not ossified well. This is appearing more of radiolucent as compared to this pillar B. So in this we will classify it as BC, and in the second image you can see how thin the whole epiphysis is. So again this is 2 to 3 mm only. In this lateral pillar is 2 to 3 mm. So we will be classifying this as BC. So coming to the management, as per the Herring classification, Herring told that all the patients who were under the group A, where the height was maintained, they do well. So no management is required. Even if we do not do anything, they will have very good outcomes. And for the C, where the height is less than 50%, most of the times the outcomes are poorer. Coming to the group B, he told that for all the patients whose age is less than 8, you just observe them, conservatively manage and observe them. But all those children who are more than 8 years, we have to do containment procedure. What these containment procedures are, we will be discussing shortly. And for the group C, where the age is less than 8, although they will have poorer prognosis, but you should contain, so that some amount of correction could be done for these patients and some prognosis could be changed towards the good side. So this is what Herring told about these classification system. And so what were the shortcomings with the rest of these classification systems? That Walden-Storm, Salter-Thompson, all of these classification systems were mainly descriptive one. They were not helping much with the management. And although Catterall classification was helpful in management, but that classification system was detecting patients in fragmentation phase itself when we are already delayed. So the child will have poorer outcomes definitely. So in modified Elizabeth Town classification by Benjamin Joseph, we detect children at earlier stages and we try to do containment procedure beforehand. So in this classification system, Benjamin Joseph unified two classifications. That is, one was Walden-Storm and one was Catterall classification. So unifying both these classification systems, Benjamin Joseph came with this classification where he divided 4 stages: stage 1, stage 2, stage 3 and stage 4. Stage 1, 2, 3 was sub-classified as A and B. What all these classes are, we will be discussing now. Stage 1 is the phase of avian, we have already discussed. Stage 2 is fragmentation. Stage 3 is reossification or revascularization. And stage 4 is remodeling. These we have already discussed in Walden-Storm's classification system. In stage 1, that is avian, whenever the femoral head height is normal, that is stage A, and when the height is reduced, this becomes stage B. So this is how it looks. Stage 1A is this, where the head is having sclerosis, but the height is normal. But when the height becomes reduced like this, with sclerosis, this becomes stage 1B. So this was 1A, this is 1B. And in stage 2A, where the fragmentation starts, whenever the fragmentation line are up to 2 only, this becomes stage A, and more than 2, stage B. So in this you can very well see one fragmentation line is visible, one fragmentation line is visible, but in this diagram you can very well see many fragmentation lines, more than 2 lines are visible. So this has become 2B and this is 2A. Reossification, whenever a new woven bone is laid down in up to 30% of the femoral head, it becomes 3A, and more than 30% this becomes 3B. So up to the 30% woven bone is present, that is 3A, and more than of the 30%, it becomes 3B. And the fourth one is the stage of healing and remodeling. So this is what Benjamin Joseph gave as modified Elizabethtown classification, which helps in the management plan. And how does it help? We will be seeing in further slides. And the last one classification, that is Stulberg. Stulberg is actually not a classification system during the active stage of the disease. This is after the healing. Once the disease has healed, we classify the hip into 5 categories. The type 1 category is when the hip is appearing very normal. Head is normal, acetabulum is normal. This is Stulberg type 1. In Stulberg type 2, head becomes either large or it becomes small, but still it is congruent with the acetabulum. So this is Stulberg type 2. And 1 and 2 collectively, they are congruent hip and they are spherical. So this is spherical congruency in type 1 and type 2. Coming to the type 3, although the head is flat many a times or head could be irregular, but in both these cases, they are congruent with acetabulum. So these categories collectively, they are aspherical but congruent with acetabulum. Now the last one, where we have incongruency with acetabulum. So this is aspherical incongruency. So what 5 stages we do have in Stulberg classification? One was everything was normal. Stage 2, where although the head was slightly small or larger, but it was congruent with acetabulum. So both of them collectively were congruent spherical. Type 3 is, although it could be flat, and type 4 sometimes it could be oval, but both of them will be congruent with the acetabulum. So it becomes aspherical congruency. In the type 5th, it will be incongruent with the acetabulum. So this is aspherical incongruency. So all these have been summarized in this diagram. The first is spherical congruency. This is aspherical congruency in this diagram. And the last one is aspherical incongruency. So we have discussed about this Stulberg classification also. Now we will be coming to the clinical presentation. We all do know that Perthes is a disease which is commoner in the age group 4 to 8 years and more common in males than females. And this is a painless hip where child presents with limp. Sometimes it can have pain also as a presentation, that is hinged abduction, but what that condition is we will be discussing in further slides. And the deformity that is found in Perthes disease is flexion, adduction and external rotation. What was the deformity in Skiffy? Skiffy was having extension deformity with external rotation, and it could be adduction or abduction, and so that you should keep in mind. Coming to the X-ray findings which are found in Perthes disease, there are certain findings related to epiphysis, certain related to physis, and certain related to metaphysis. What all these findings are, first we will be discussing about findings at epiphysis. First finding that we should always keep in mind that due to ABN, the head can appear as sclerotic and head can have normal or reduced height. We have already discussed about that in Elizabethtown classification. Second, in the epiphysis, we sometimes have V-shaped radiolucency. That is also known as gaze sign. What that gaze sign is, we will be discussing in further slides. And the third one is lateral subluxation. When head starts subluxating out of the acetabular socket, more than 20% of the lateral subluxation is something which is important to us. Fourth one is lateral calcification in the epiphysis. So these all are the findings which are found in epiphysis. And how does these findings do appear, we will be seeing. In this radiograph, you can very well see this epiphysis is appearing sclerotic and height is also reduced. So this is sclerotic with reduced height. Coming to the next radiograph. In this radiograph, you can see that lateral part of the epiphysis is having calcification, and you can very well see that the height is reduced for this epiphysis, and this is also showing fragmentations, and you can very well see that this head is extruding out. So nearly 40% of the head is out. So all these findings are evident in this X-ray. Now physis findings, I have already told you that certain findings we will be seeing in physis also. What these findings are, physis could be irregular and it could be horizontal. So these are the two findings which are found in phthisis. Coming to the metaphysis, what findings we can find in metaphysis? One is metaphyseal cyst. This is an important finding which is also a poor prognostic marker. We will discuss what all are the head at rest signs. Second is increased medial joint space. This space can sometimes be increased in these patients, and sometimes the child does have coxa brava, that is short neck. These all are the findings which are found in metaphysis. So in this radiograph, I am showing you increased metaphyseal medial joint space, that is also known as Waldenstrom sign. This is important sign which is found in Perthes disease. Now coming to head at rest signs, these signs were given by Catterall. So these signs whenever present on radiograph, they are poor prognostic signs. So also known as head at rest signs by Catterall. So what these signs are? Three signs will be present in epiphysis. What these are? One is lateral subluxation. We have already discussed lateral calcification. And one is gauge sign. That is V-shaped radiolucency. How does it look? We will be seeing. One in physis, that is horizontal physis, and one is metaphysis, that is metaphyseal cyst. I have already told you. So what these five signs do look like? In this radiograph, you can see lateral calcification, that is one sign. Another one is metaphyseal cyst, that is another sign. Coming to the next radiograph. In this radiograph, you can see gauge sign. This is V-shaped radiolucency in epiphyseal part. So third sign I have already shown you. And the fourth one is lateral calcification and lateral subluxation. So all the signs I have shown you. Coming to the prognostic factors which determine poorer prognosis for the patients. So what is the value of all these poor prognostic factors? The age more than 8 and lateral pillar shape, that is type C. These are the most important poorer prognostic factors. They will help in determining the prognosis of the patient. Whenever these two factors are present, the child is going to have poorer prognosis. So if I do write prognostic significance over this area, and I tell you what is the prognostic significance of all these parameters, the age will have this much amount of the significance. Whenever the age is more than 8, the child is going to have poorer prognosis. And the lateral pillar shape is also having this much of the prognostic significance. But lateral calcification and subluxation, these were head at rest signs. These will have significance less than the first two ones. And the mobility of the hip and sex, that is female sex, they do have prognostic significance, but that is even less than lateral calcification and subluxation. So this is how the prognostic significance reduces for all these factors. And the gaze sign and horizontal physis, these are also head at rest signs, but their prognostic significance is even lesser than rest of the factors. So coming to the management part, we should know that in Perthes disease, head becomes deformed. And that deformed head gives rise to arthritis. This is the complication which can happen. So what our aim should be, we should prevent the loss of the sphericity of the head so that arthritis could be prevented. This is the aim of the management. And how can we achieve this aim? We will be discussing. So what all changes the head can have? So if this is the femoral head in a normal patient, a child with Perthes disease, when develops irregular head, he can have a large head, that is coxa magna. A child can have irregular head, that is coxa irregularis. A child sometimes can have a short neck, that is coxa brava, and sometimes this trochanter overgrowth. This is trochanteric overgrowth. So this is how different head changes do present in a child with Perthes disease, and our aim is to prevent them all. And if ever any of these changes do develop, we will have certain salvage procedures to give the child symptomatic relief. We will be discussing about that. So the management in a child of a Perthes disease will depend upon certain factors. What should be done will depend upon certain factors. In Elizabethtown classification, we have discussed about some stages of the disease. So up to stage 2A, that was early fragmentation stage, up to the time when only 2 fragmentation lines are present, we can do preventive surgeries. We can prevent development of irregular head. But whatever we are doing will depend upon the age of the child also. Whether it is less than 6, whether it is 6 to 8, 8 to 12 or more than 12, we will be discussing about these shortly. So the management will depend upon the stage of the disease. It will depend upon the age of the child, and it will also depend upon the extrusion, that is subluxation of the head toward the lateral side, lateral subluxation. So these are the 3 most important factors, and apart from that, one more factor is mobility of the hip. So this is the 4th factor. So upon these factors will depend our management. So first factor is age of the child. Whenever the age of the child is less than 5, we don't need to do anything. We just observe the child. This is also known as supervised neglect. These all we are discussing up to stage 2A of Elizabethtown, up to 2A only. What should be done after 2A, we will be discussing in further slides. So up to 2A of Elizabethtown, that is early fragmentation stage. If a child is having age of less than 5, this is the one category, we have to do nothing. Whenever the age of the child is 5 to 8, we have to see if the child is having extrusion or not. If the child does have extrusion, that is more than 20% of the extrusion, then we have to contain it. Otherwise, nothing is to be done. For children between the age of 8 to 12, what Benjamin Joseph believed, they do always progress. So we do always contain. Whether the child do have extrusion or do not, we do not see, we always contain. And for children more than 12 years of age, they will have poorer outcomes whatever you do. So we have to do salvage procedures once the disease heals. So this is how, depending upon the age and extrusion, up to the stage of 2A, Benjamin Joseph decides the treatment for these children. Now we will be discussing some pitfalls, limitations of this classification system where the Benjamin Joseph might be wrong. So there are many believers that he is doing too many osteotomies. What does it mean? There are many children between the age of 5 to 8 year of the group where although extrusion was present, but they might not progress. And in the age 8 to 12, there are many children where extrusion was not present. Extrusion was absent and extrusion might not happen. So even for these children, all these children, osteotomy was done in this classification system. So we might be doing too many osteotomies. So there are many authors who do believe that this is a shortcoming of this classification system. So according to the stages of modified Elizabethtown classification, up to 2A, I have already told you, we have to do containment surgery. That is a preventive procedure mainly done by VDRO, whereas derotation osteotomy. But after 2A, what has to be done? After 2A, we have to do remedial surgeries whenever the child have hinged abduction. What hinged abduction is? This is a painful condition. We will be discussing about this in further slides. And after that, once the disease has healed, we have only salvage procedures with us. We will be discussing about all these salvage procedures. So up to stage 2A, depending upon whatever the age of the patient was and whether the extrusion was present or not, Benjamin Joseph decided what should be done. After 2A, remedial surgeries should be done when hinged abduction is present. And after healing, we are left with only salvage procedures. So preventive surgery, I have already told you, for all those children who are having stage up to 2A, who are having good range of motion, who are having extrusion, VDRO should be done as a preventive measure. This is the preventive surgery. And once the child has crossed the limit of 2A, we have to do remedial surgery. But there are many children who are before the stage of 2A, but not having good range of motion at hip. In these children, we have to apply traction for maybe 2 to 4 weeks. And once good ROM is achieved, then we have to do containment. So this is one thing you should be keeping in mind. What all factors we have discussed which will decide management? One was stage of the disease, one was the age of the child, one was extrusion, and one was the range of motion of hip. I hope you have understood about all these factors and how they help us in deciding the treatment. And after stage 2A, what all possibilities a child can have. Once the child has crossed stage 2A, that is early fragmentation. Sometimes the child do not have any symptoms. The hip is contained and the child is pain free. This is the best scenario. We don't need to do anything. Don't do anything. But many a times the hip is having extrusion, but still this is pain free. In this scenario also, if the hip is stable, don't do anything. Wait for the disease to heal, then we will see whether salvage procedure is required or not. Now comes the concept of hinged abduction. Sometimes the hip is uncontained, that is, it is having extrusion. And whenever a child does abduction, the hip starts getting out of the socket and the child have very painful condition. This is the concept of hinged abduction that we will be discussing now, and this is the condition when remedial surgery has to be done. So in this diagram we can see whenever the femoral head is rounded, normal contoured, in that case whenever this child is doing abduction, the rotation will be happening at the center of the femoral head. This is normal abduction. But if a child have a bump over this area, and now if this child is doing abduction, what will happen? The rotation is not happening at this site. Instead, the rotation will be happening at this site, at this hinge, so that with the abduction, this space over the medially will increase with abduction and the child will have very painful condition. This is the concept of hinged abduction. So in this scenario, range of motion is not happening at the center of the rotation of hip, but the center of rotation has shifted to this bump. This bump is acting as a hinge so that the hip is getting out of the socket and the child is having hinged abduction. In this radiograph, you can see very well that after the arthrogram, there is too much medial pulling of the dye over this area because a bump over here is having hinged abduction movement when the child tries to abduct the limb. So this is the arthrogram findings in hinged abduction and what needs to be done. In hinged abduction, what we do valgus osteotomy. We bring this limb in adducted position so that this deformed area, this hinging part comes out and the normal area of the femoral head, this will start articulating now and we fix it. So this is the concept of valgus osteotomy that is done for hinged abduction. And we should always keep in mind that with the valgus osteotomy, the head is getting uncovered. This much uncovering is happening. So this is kind of an unstable osteotomy. After doing valgus osteotomy, many a times hip becomes unstable. So if ever it becomes unstable, we have to do many pelvic osteotomies also like Shell, Chiari. So these coverage procedures might be needed whenever we are doing valgus osteotomy. Now coming to the another category. In more than 2A stage of Elizabethtown classification, we were having hip which was not painful, that was pain-free hip, and that was not having hinged abduction also, but it could be unstable. So for these cases, we might require coverage procedures. So after stage 2A, remedial surgeries are needed for hinged abduction, that is valgus osteotomy, and for all those cases where the child is having pain-free movement at the hip, whether it is contained or not, but the hip is unstable, in that case also a remedial surgery, that is coverage osteotomy for the acetabular site might be needed. So these two type of remedial surgeries might be needed after stage 2A up to stage 4 in Elizabethtown classification. And once the disease has healed, what salvage procedures are needed, we will be discussing about them. So after the healing of the disease, what is shown in this diagram is this head is irregular. So coxa irregularis is there. Short neck is there. Coxa brevis is there. This neck is very short. This trochanter is overgrown. So trochanteric overgrowth is there. And this child is likely to have femoral acetabular impingement whenever he is trying to abduct the limb. So all these are the problems with this healed disease. So what should be done for this child, we will be discussing shortly. But before that, I shall tell you about Stulberg classification. We have already discussed. There are three classes mainly: spherical congruity, aspherical congruity, and then aspherical incongruence. So depending upon whichever class is there, we will be discussing our treatment. For class 1, mainly no treatment is required. Mainly for type 3, you have to do either replacements or arthrodesis. Not done these days arthrodesis, but historical importance. But this is the category of type 3 and type 4, where most of the surgeries are done in salvage procedures. So what these surgeries are, we will be discussing. So firstly, we should discuss what all could be the problems with Stulberg type 3 and type 4. So I have already told you that the head could be large, irregular, with trochanteric overgrowth, with short neck. So this is how a healed disease in Perthes looks like, and this is the acetabulum. So what all could be the problems? One problem could be if this head is irregular over here, this can have cam type of FAI. Second, because of this trochanteric overgrowth, whenever the child is doing abduction, he can have external impingement also. The first one was, this was internal impingement, this is external impingement. Okay. The third problem this child can have, because of the short neck, abductor lever arm is hampered and abductor insufficiency can happen. Apart from that, external impingement obviously can happen. So these are the problems because of short neck. Fourth, because of the trochanteric overgrowth, again, child can have abductor insufficiency. And at last, child can have labral tears and cartilage tears. So these we have already discussed. Now coming to the first one that we have discussed, that is internal impingement because of cam over this area. Whenever a cam is there, what can we do? We can excise it. That is osteochondroplasty. So that cam type of FAI can be resolved. The second one is external impingement. That was happening because of the short neck and trochanteric overgrowth. So what can we do? We can osteotomize this overgrown trochanter and we can shift it distally. So once we have shifted it, we have relatively lengthened the neck and we have distalized the abductors so that the abductors are now functional and neck has lengthened relatively. So even external FAI is resolved and abductor insufficiency is also taken care of. So this procedure is relative neck lengthening in external impingement. And whenever a child is having unstable hip, what can we do? We can have coverage procedures in acetabular side, shell and Chiari. These all are the procedures we can do. So this is all I wanted to discuss about Perthes disease. I hope you found it useful.